Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. All right, well, welcome back to this episode of Coffee with Coker. And today we have a new guest, and I'm really excited about this discussion and our guest today. So I will dive right in, but this is an opportunity for us to talk with a physician. And we've done this a number of times in the past, but we have the benefit of getting a perspective from a clinical professional as well as a healthcare business professional on kind of all things going on in the healthcare market right now, which is obviously very relevant to our audience. But as we dive in, I want to take a minute to introduce Dr. Brent Lacey. So Dr. Lacey, welcome.
Hey, thanks for having me, Mark. I really appreciate it.
Yeah, well, I thank you for joining us. And before we jump into our discussion, I'd like to give an opportunity for you to talk about kind of your background and what you do and just introduce yourself. So take it away.
Sure. Well, I'm a full-time gastroenterologist, so still practicing. I'm down in Dallas. Spent 15 years in the Navy before I went to civilian practice. And one of the things that I observed after I came out of training was that physicians coming out of medical school and residency and fellowship were really excellent at being doctors and pretty lousy at everything else to do with either the business of medicine or the business of running your own personal finances. I mean, I would see people just in tremendously high, levels of debt and just no clue of how to actually run a clinical practice. And I thought that was bad and needed fixing because, we're not doing that at the medical school level. I haven't talked to anybody who had significant training on those topics. And so that's why I started The Scope of Practice, which is a blog and now a podcast to try to help give physicians the knowledge, the resources, the encouragement they need to be able to run their own practice successfully and master their personal finances.
Yeah, that's great. And I'm glad you mentioned the podcast because we're actually going to record a episode of your podcast where I will join and we'll make sure in the show notes for this episode, we'll link over to your podcast and your website and blog. And so people can follow that because it has a lot of just very insightful information that it's funny you mentioned that about training on the business side or professional side of medicine. We've seen the same thing. And frankly, it's kind of why Coker Group exists. Our role has been to help on the business side of healthcare to support what the providers do on the clinical side every day and have for years. And, it's interesting. And maybe that's a good way to kind of jump in because what we found is there's so many great resources out there, such as yourself and what you do and your experience that can help bridge some of that professional, financial, operational side in terms of adding efficiencies and improvement. And where we come in, frankly, is usually something very significant or something very unique, I should say, where it's a one-off thing that just doesn't make sense. Or it's just not going to be in the wheelhouse for a lot of your providers, your practices, your practice administrators, and on the hospital side as well. So I guess what I'm saying is there's a lot of progress that has been made on the provider side to benefit themselves on some of those non-clinical things. And I guess I'll ask you, what are your thoughts as far as where providers are today when it comes to dealing with those things? Are we better than we were 10, 15, 20 years ago on dealing with some of the non-clinical aspects? Or are we still getting there? Or is it there's still a really big gap to bridge?
No, I think on the physician side, there's still a tremendous gap. If it's better than it was 15 years ago, I would say the improvement is marginal. And I think that has to do with a couple of things. One is that there's no training. There's no formal training in any of the med schools or almost any of the med schools. I have a buddy at University of Arkansas that's got a program that they're doing. And there's a few other places like my alma mater of University of Texas in San Antonio. Their dental school has a 4-year curriculum that they do for their dentists. That's really, really impressive. But those are outliers. And so there's really no formal training mechanism. The second thing I find is that most of the time people that are going through med school, they're, mostly coming through college and then med school or maybe grad school or some kind of, research background, but very few people have any kind of significant business experience. So they're not getting any real world experience prior to med school either. And then once you graduate and you start your job, you're in a full-time clinical position, people don't really have a lot of time to learn that. And so I think it's been lack of knowledge, and I think it's been lack of training. And then, ultimately it ends up being lack of time or maybe lack of motivation or both for people to go do that. So there's still just a tremendous gap. Now, fortunately, there's a lot of folks that are springing up in the last 5 or 10 years that are talking about the personal finance side of things. There's probably 80 or so of us that are blogging about personal finance for physicians, and maybe 8 or 10 of us that are doing podcasts, but there's precious few that are doing anything with regard to business management, how to hire and fire, how to strategically plan, how to cast vision, how to lead a team, things like that. And so I think that's still a tremendous gap that we need to bridge.
So you mentioned a couple of things there that jumped out at me. I completely agree. And we've seen a lot of that, whether it's personal finances or practice finances or leading teams and hiring and firing. Is there any kind of one area or one or two areas where you think are the biggest pitfalls right now that you're seeing from the physician's perspective?
I think the two biggest ones are personal finance and leadership capabilities. I mean, when physicians come out of training, the average amount of med school debt the average amount of debt for a medical school graduate is over $250,000. I mean, you're starting $250,000 in the hole. And unfortunately, way, way, way too many physicians, they've been holding their breath, right, for college and med school and residency and fellowship. They've been holding their breath for 15 years. And all of a sudden they take a big exhale. And in that exhale, they buy a big house and they send their kids to private school and they buy a couple of Teslas. And, none of those things are evil. And, go get you a Tesla if you want. That's fine. I'm not mad at you. But, they're in a position where all of a sudden they go from $250,000 in debt to now $550,000 in debt. And then it's time to buy into a practice. And now I'm $1,550,000 in debt. And you look around, you're like, I have got $15,000 a month in debt payments. How did that happen? Right. And so that's a big problem. And then the second thing I think is from a leadership standpoint, and this is one of my big passion projects, is trying to engage physicians in clinical leadership. Because what we've seen, if you look at, national statistics, by and large, physician-led hospitals tend to be more profitable. They have higher safety ratings. They have better patient satisfaction scores. They're just better. But that's a very small minority of the hospital and healthcare organizations across this country. And I think part of that is that physicians lack the proper training. And I think part of it is that they lack the motivation. And, because they're like, well, I'm just going to put my head down and see my patients. And that's enough for me because that's a full-time job. And I understand that. But at the same time, I feel a personal burden to take on the ownership of leading my team and leading my practice. And, even as a junior partner right now, I feel like that's something really important for me. And I want to encourage that in other physicians.
That scenario where you talked about where that debt is building up and before you know it or before they know it, they're dealing with just incredible monthly debt service payments. What's kind of the way to dig out of the hole? What are some of the key things you tell folks as far as here's where to start thinking about how to not only dig yourself out of that hole, but to prepare yourself more for more future success and growth financially?
Well, I try very hard to catch people as early as possible. So if you can catch people in med school and residency and fellowship before they get that first attending paycheck, you have a much higher shot at helping them stay out of a giant hole. And so what I always tell those folks is don't buy stuff you can't afford. I mean, it sounds simple, but I mean, I think as physicians, debt kind of becomes almost like a way of life, or is almost an inevitability. We say, okay, well, it's very difficult to go to med school, debt free. Some people do it. I mean, I went through on a Navy scholarship, so I went through debt free, but very few people actually do that. And so you expect that when you come out of med school, you're just going to have a lot of debt. And then so the mindset becomes, well, what's a little bit more? I mean, I'm already in a lot of debt and it's time for me to start living. And one of the phrases that I try very hard to get people to stop saying is, when's it going to be my turn? Right? Because they see their friends' Facebook pictures of vacations and new cars and new houses and all these things. Are like, when's it going to be my turn? When's it going to be my turn? It's like, if that's the question that you're asking, you're definitely going to fail from a personal finance standpoint. You got to start asking the question, what do I want and what does it take to get there? And most of the time, what I tell people is that you can achieve almost all of your goals, but it's not about what you're willing to do for it. It's about what you're willing to give up. So are you willing to send your kids to public schools for a while? Are you willing to live in a smaller house? That's one of the biggest things, the mistakes that physicians make, is buy a giant house right out of med school. And that is, just the death knell for most of their personal financial struggles. And so, I tell them, don't buy things you can't afford. Don't let debt become a way of life, and cut your budget, cut your expenses to the point that you can make a significant dent in your debt starting on day one. And so I tell people, I want you out of all debt within 5 years after graduating from whatever your final stage of training is. And people hear that, they're like, that's ridiculous. It's going to take me 15, 20 years to climb out of that. I was like, if you do that, you will set yourself up for failure in your retirement years. Debt does not need to be a pet that you keep around like a puppy. Okay. You need to kill it. You need to excise it like a cancer, get it out of your life. And you need to treat it that way, like it is actually going to ruin your life, because it will.
Well, it's funny because as you were talking about that, I was thinking about, it may sound a little hokey, but the old quote that, comparison is the greatest thief of joy. But I think in this case, it can also be in a world of social media and comparing, what physician A is seeing from physician B and C on their social media and pictures and all that. And just, hearing the discussion around the dinner table when they get together, it can be a huge thief. That kind of comparison, I would think, could be a huge thief of just financial success.
100%. I had an interview on one of my early episodes of my podcast with Sarah Stanley Falah. She wrote The Next Millionaire Next Door. And one of the concepts she talks about that I've adopted that I love is the concept of social indifference. And so it's the old keeping up with the Joneses. You got to stop caring what the Joneses are doing. And it's exceptionally difficult nowadays, now that the Joneses have gone digital, right? And so everybody sees everyone's highlight reels on Facebook. Nobody posts bad pictures of themselves on Facebook unless you're a celebrity trying to show, post a bad picture deliberately, showing how brave you are for posting a bad picture deliberately, right? But nobody posts bad pictures deliberately. Everything is Pinterest perfect. And so you're looking at everyone's highlight reel and trying to compare yourself to that. You have to become indifferent to what other people are doing, in the sense that you're not trying to achieve that immediately when you can. Not to the point where you quit caring about your neighbors, or that you become calloused, but that it doesn't come into your heart as something that you say, okay, I definitely need that right now. You have to be able to look at those things and be content to be joyful for their great success without claiming the mantle that you need to do that in order for you to be happy.
Yeah, I mean, that's great advice just in general. And I think it's an extremely healthy perspective for physicians, particularly looking for kind of future financial growth. I want to go back to talking about leadership, because this is one of those things where our firm, Coker, has been doing much more on the hospital side, I would say. There's a lot of, from a strategy perspective, leadership is just becoming a key gap for many organizations. And as hospitals and practices continue to align more closely, whether it's through very formal affiliations or looser affiliations, those lines for a number of years have been, or those walls have been broken down. And we are seeing more physicians coming into leadership positions, and whether it's on the hospital side or their own practice, their own groups, or something in between, maybe. What are some of the things you've seen there as far as gaps? And then, looking at those gaps, what are some of the solutions you think you've talked about with some of your cohort?
Yeah, it's a great question. So I would say a couple things. One is I see a lack of motivation. And, the biggest struggle that most physicians face is, having enough time to do their work adequately and still be able to balance that with stuff in the family. So, asking someone to take on a leadership role of some kind, it's not that it's, the end of the world. It's that it's another thing. Right. And people hear that and they're like, oh my gosh, I can't imagine taking on some other thing. So people are generally unmotivated because they feel like they have a lack of time. I think part of it is lack of confidence. They feel like, well, who the heck am I? Who's going to listen to me? I don't know anything. I've never led a team. And so I think that is also part of it. And so what I always tell people is that the best way to make change is to participate in the change. And I think that's probably a third big thing is cynicism or a lack of belief that they can actually make a difference, because they feel like, oh well, nobody's going to listen, nothing's ever going to change, and they just kind of, it's like they just are sad and mopey about it, and they're like, well, I guess there's nothing we can do. I guess it's like they're channeling Eeyore from Winnie the Pooh or something. And what I tell people is, look, just start with something small. Okay. A lot of decisions in big hospitals or in healthcare organizations, a lot of decisions happen at the committee level. And that is a way that you can make significant inroads into leadership with fairly minimal time commitments. So for example, if there's a committee for, ethics, right? There's a lot of good work that's done by the ethics committee. Okay. So it helps get rid of problem, doctors. It helps, bring in folks that are really, really outstanding. It helps celebrate and champion, good qualities for your organization. That's a great way to get involved. Most hospitals have some physician representation on all or most of their hospital committees. And a lot of that is based on their bylaws. Actually, it's almost required. And so just go for that. There's oftentimes very little competition for those things because people just don't want to do it. So just volunteer and start getting on some of these hospital, committees. That's a great way to start. And if you're in just a practice, I think the thing that people don't understand is that leadership is not something that comes from above. So authority is not given to you from the people above you. It's given to you by the people that are below you, okay, or the people that are working for you. So as a physician, you naturally are in a position of leadership from day one when you start working, right? Because your nurses are going to follow your lead, your techs are going to follow your lead, your peers are going to come to you for advice, even if you're a junior guy in the group. And so you are naturally already in a position to leverage influence. And so take advantage of that. Teach people, show people, just show people that you are willing to give of your time and your knowledge to help make them better and help make their jobs better. And you'll find yourself already in a position of leadership just from that. And if you can demonstrate yourself, if you ever heard the expression, don't dress for the job that you have, dress for the job that you want, right? And so if you can prove yourself competent and, even exceptional in the job that you're already in, someone from above is going to look at you and go, man, he's doing a really good job. The nurses respect him. Everybody, he's kind of the go-to guy on this issue. I'm going to see if maybe he's interested in doing this next thing, right? And so people will start to notice, if you've got good leadership in your hospital, they are always looking for good leaders to join them.
I think that's such a great point because it is very clear the distinct or the divide between poor versus quality leadership in a hospital. And it does. I think it's interesting that on your list of some of the things that are perhaps holding back leaders and the motivation is on that list was nothing related to income or compensation. And I think, it's a factor, particularly when you think about if they are going to have to commit extra time to it. But from a hospital's perspective, in our experience and what I've seen, if the structure is set up correctly and effectively, for instance, through committees, if the structure is set up right and the proper leadership is in place, then that extra commitment doesn't have to just all fall on one person. Meaning, if you are volunteering for that ethics committee, it's not just you're on a committee. It's not just you. You're not going to have to do everything. And if there's lack of confidence, you can be confident in the fact that it is a committee and there are others, and you have extremely valuable contribution. And at the end of the day, hospitals, like you said, a lot of them are required to have physician participation in those types of committees and operational matters. But even if they're not required, it's invaluable. And the presence of that kind of leadership is very meaningful downstream in every way when you think about a hospital's operations. And same thing with a group. So I like that approach in that you don't have to bite off everything at first. Also kind of incrementally participating in some of those different committees where you have either unique expertise or just an interest and our willingness to commit a little bit more time, they're great building blocks, stepping stones for something bigger. So, and I've seen that happen throughout the course of careers.
Well, and the other thing is that you don't have to necessarily be on a committee to effect change through the committee. So let's say there's something that you notice is a big problem. Let's say that you've been noticing that there is a tremendous efficiency shortfall. For some reason, like you just, month after month, there's just like a 20% no-show rate and you're not sure what's going on, and you have no idea how to fix that. You may not be the best person to address that problem, but you're someone who noticed. Okay. So you can bring that up to somebody, figure out who on your, what is the organizational structure of your healthcare organization? Who is someone you can take that problem to and let them address it? So you may not even have to be the person that's on the committee making the change. You can alert the change, or bring up the problem to someone who is in a position to address it.
Yeah, just asking the right questions or just asking any question can lead to change. So that's a great point. I do want to talk about, we can't avoid talking about the current state of what's going on, not just COVID-19, but how it is affecting the healthcare industry. And I really, not being a clinician myself, obviously, I love to get the perspective from our clients and the physicians that we know and work with and talk to out there, such as yourself, about this whole thing. And particularly, I want to look at kind of current state and where we've come, but and even get perspective from your practice, but thinking about the future. But before we get to post-COVID, let's just kind of talk about, if you don't mind, give us a little bit of your perspective on interacting with patients and managing patient care, doing all the things that you need to do and want to do as a physician, as a provider, but in the context of a global pandemic.
Yeah, so I think we got to separate inpatient from outpatient. So sure. From an inpatient side, I think things have changed actually very little. With the exception, obviously, of wearing masks and potentially more significant personal protective equipment if someone is known to have COVID. Other than those safety things, the interaction on the inpatient side, I think, has actually changed very little. On the outpatient side, it's been an interesting evolution over the last 6 or so months, and we were basically at 100% telemedicine or nearly 100% telemedicine, except for, say, emergencies for quite a while there. And we're starting to bring back, more patients. I think that the future of medicine is going to be much less dependent on telemedicine than a lot of the talking heads would like us to believe. And here's the reason why. A very unfortunate thing has happened, I think, in the last 15 to 20 years. And that is that as healthcare has become a significant policy issue in American government at the state and national level, when you bring the conversation to those levels, it tends to become very abstract. And it's very common for the different components of the conversation to become commoditized. And so people start to think of every hospital is the same. You have one hospital and the other hospital in town, they're the same. It's just which one can you get into? Which one is your insurance company going to allow you to be? And which medicine is the same. All medicines, all proton pump inhibitors are the same. All cholesterol medicines are the same. And worst of all, they start to feel like all healthcare professionals are the same. Every doctor is the same. You have a gastroenterologist, there's a gastroenterologist over there, whatever, whoever's available first, just go to them. And we know that that's simply not the case. I mean, just as in your industry, there are the term I like to use is varying degrees of excellence. But you know how it is. I mean, there's some physicians that frankly are kind of lousy. I have a list of people that I never, ever refer patients to because I know they're just not very good. And I have, physicians that I think are good enough. And then I have physicians that I think are exceptional that I make sure that if I've got something really challenging or really weird, that they're my go-to person. And so this commoditization of the healthcare industry has, I think, generated a couple of problems along those lines. And one of the things that people, just to answer your question, that people, I think, don't fully appreciate at the government level is that people want a relationship with their doctor. So I think telemedicine is going to have its place, for some things, medication refills or something that's a fairly simple, straightforward, just, hey, doc, I got a question about this issue. But by and large, people want relationships with their physicians. They want to be able to know that they can just, go in and see their doc the next day if they've got something that's bothering them. Like, hey, my kid's maybe got an ear infection. I want to take him to my pediatrician. And so they don't think of all pediatricians as the same. They don't think of all gastroenterologists as the same. And so I think telemedicine is going to have its place, but I think it's going to be a minority of the encounters that we'll have once we get beyond a certain level with COVID.
Sure. Yeah, I would agree. We've found we've done a lot of work on telehealth this year, and we saw the numbers of the adoption rates spike up from like 18% to, I don't know, 80% or something like that. And early on, like late spring, early summer, and then kind of late summer come back down to, kind of historical levels, or maybe let's call it 20 to 30% adoption and utilization. And that's probably, I think, where we'll see it. I mean, yeah, it's here to stay, but I think you're absolutely right. I mean, there are things that just can't, there are many things that can't be done virtually or via telehealth or other solutions that may be out there coming along. But then there are other things that just you would rather not do. You would rather see your patient. You'd rather have that personal relationship, face-to-face dynamic. And even if technically it could be done virtually, there's still, I think, going to be a, sentiment of or some sort of preference towards being in person.
Yeah. And, one of the big trends that we're seeing in primary care right now is the rise of direct primary care. And, there's concierge medicine, but direct primary care is, concierge medicine for everybody else. It's an affordable way to, have a relationship with your doctor, but basically without insurance, right? It's just a monthly subscription model. People love this. I mean, I've got a lot of friends that have gone into direct primary care and they love it because they get to have a real relationship with their patients. I mean, when you're seeing 40 patients a day and you get 7.5 minutes per person because of all these different, metrics and, documentation stuff that you got, it really sterilizes the interaction, unfortunately. And so you don't get that really warm, relational aspect that most physicians got into the business for, and which most patients really crave. So I really think we're going to see a significant return to in-person interaction.
I got to think there's an element there, Brent, that is when you think about some of the things you were talking about as far as direct primary care and concierge care and things like that. I'd be curious to get your insight from a clinical perspective as far as the quality component to that, because I would think there's the more you improve that dynamic and you decrease the commoditization of medical services, like you're referring to, that there's going to be likely to be some sort of correlation to quality. What's your perspective there?
Yeah, I think that's right. If you are able to spend more time on any given project, whether that's working with a person or building something or whatever, you tend to be able to produce a higher quality product because you have more time to devote to it. So one of the things that is a significant complaint among physicians over the last 15 years is the dramatic increase in documentation requirements and focus on, healthcare metrics. And, I'm always torn on that discussion because, as a physician leader, I recognize the value of having those kinds of things just simply because, as we were talking a little earlier, we recognize that there are some physicians who are just not very good. And unless they're forced into a position where they are being tracked and they have to modify their behaviors and their practices in order to meet certain minimum standards, they won't meet those minimum standards. And so it's good to have those things from a patient standpoint, but for everyone else who's already doing their job, it's just more busy work. It's nonsense. And so, it's the kind of thing that tends to frustrate me because, from an enterprise-wide system level, I recognize how important it is to have those things be, something that we champion as a group, but it's also annoying because I know I just don't need it because I'm going to do a good job no matter what. And so from the direct primary care standpoint, and the concierge standpoint, I think that that's really valuable. But, those are fairly small niche markets. And I think there are ways that you can do those same kinds of things in any practice, but it almost always comes down to allocating more resources. And either that's time from the physician or time from someone on the staff or some kind of a service that increases efficiency that maybe allows for a better exchange of information between provider and patient.
Yeah, we've seen it. It's funny, a million times it seems like, when we're talking about like technology and electronic health records and those types of things, the having to train physicians on those platforms, but make sure it's not done in a way that is impeding that dynamic where the physician is just clicking through screens the whole time as opposed to actually talking to and engaging with their patients, rather than clicking things on a tablet or a laptop or something. And I think that same principle can apply to what you're talking about. As we think about kind of going back to where we are today and some of the things that you were talking about earlier, I think as far as financial health and stability there, planning, as well as the leadership element. But particularly when we're in a world now where volumes for this year, I think widespread are going to be significantly lower. Hopefully, they won't be what they were in April and May, and I don't think they will be. But when you extrapolate 2020 as far as volumes and operations and financial performance of a group that ties directly to the performance of and the volume of an individual provider, what are some of your thoughts there? What have you seen from some of your colleagues and some of the physicians you work with out there as far as how they're dealing with that, how they're impacted by it, and then any sort of kind of insight as far as what we can do looking forward to plan for that?
Yeah, it's a great question. Well, and I think one of the questions that we need to ask before we answer that question is, what is our ultimate philosophy about taking care of patients? We are in the business of medicine, but we have to make sure that we're getting the polarity right. So we don't take care of patients so that we can make a lot of money. Okay. We run a great business that's efficient and profitable so that we are able to do good medicine. Okay. So it's really important that we get the polarity right. So once we've established that, now the question is, okay, so what are our numbers looking like? Well, when they slash, for example, I practice in Texas, and when they shut down the states, 6 months ago, it was a complete disaster, right? So, we basically went to emergency services only. And so we're doing, telehealth and, maybe 5 or 10% of the number of procedures that we were previously doing. And yeah, from a business standpoint, it's frustrating. But I tell you, the thing that was really frustrating for me is sitting there going, okay, I've got a patient that they're having some symptom. Let's say they have some, mildly low levels of their blood count. Well, it's probably just a dietary deficiency of some kind, but what if it's cancer? And if I have to wait 3 months to get this person into a procedure or something, and it turns out they had cancer, that 3 months could be the difference between surgery fixing things and needing chemotherapy, right? It was very, very, very frustrating. And so I think we're going to see that the numbers are way down for the year. And I think that needs to not matter to us very much. We need to just sort of take our lumps. Now, I know for like in my group, for example, the docs went something like 3 months with no paycheck. We were all working for free. And working like absolutely crazy, as much telehealth as we could cram in, as many procedures as we were legally allowed to do. We had to furlough a tremendous number of our staff, and we're only just now being able to bring them back. And we're all working just to keep the business afloat and see as many patients as we can and take care of what patients we're allowed to within the restrictions that we have. And, we just had to make some really, really tough calls. And we have brought nearly all of our staff back now. And, we're back up to full speed, but with a higher reliance on telemedicine, at least right now. But yeah, we just sort of decided those last few months, those were pretty awful in terms of finances. People are running pretty lean budgets in their households. And you know what? When you're a physician leader, that's the right decision. You just got to do that. If I'm going to be able to look my staff in the eye and go, listen, I know I had to lay you off, but hey, I was up here just, and I wasn't making any money either. It's a lot easier for me to look someone in the eye and tell them that than to say, yeah, I was out golfing every day and doing whatever I wanted. So we got to get the polarity right on those conversations.
Well, that's extremely refreshing, just because it's dose of honesty, and it can be tough to chew, but it is the reality. And I think the majority of your colleagues out there, the other clinicians, physicians, that I think they view it the same. It's just, it is tough, but you're right there in the thick of it with them. I also have to think that when you're talking about, it's not just your group and your practice, we're talking about your patients and thinking about your patients, because there are other specialists that your patients may come from or need to go to, like for instance, if it's some sort of oncological scenario. And so you're having to rely on what those other docs and what those other groups are doing as well, I imagine.
Yeah, for sure. And there's a lot of interdependence, especially in my field. I mean, in GI, I work very closely with colorectal surgery. Obviously, all the primary care docs out in town, the general surgeons, the hospital. I mean, the oncologists, as you mentioned, nutritionists. Yeah, there are tremendous ripple effects, and so anything that affects me affects other people, and vice versa. So, let's say you're in a town where you only have one colorectal surgery group, and they're running so close to the margin that that they're not paying attention to closely enough to their expenses and their income, and they don't have any cash reserves. And then COVID happens, and they go 3 months with no paychecks, and all their loans come due, and they can't pay it, and they have to shut down. Now that town is without colorectal surgery. Well, that's bad for the patients, and so it's those kinds of realities that make me really purposeful about trying to exhort other physicians to take ownership over their practices and take a more active role in leadership in their healthcare organizations, so that we can try to avoid those kinds of things, because we want to be able to take care of our staff. We want to be able to take care of our patients.
Yeah. So bringing this full circle, I'd love to get your thoughts on, as we continue to navigate through the situation of COVID-19 and the ripple effect through not only our lives, but through local healthcare systems and communities. And thinking about planning for a post-COVID world, any thoughts there as far as, how we can be looking ahead today towards, let's call it early fall, late summer of 2020, and thinking about whether it's 2021 or whenever this thing is really under control, and how to plan for the future if something else like this happens again, or just kind of rebuilding after some of the challenges we faced. Any thoughts there?
Yeah, I think it's going to have to be done in phases, and everyone's going to be a little bit different. So it will also depend on where you are. So as of right now, the time that we're recording this, New York City is still completely shut down, and so what's going to be reality for folks there and in California, where the local governance has different rulings than say Florida or Texas or Iowa or Nebraska, those are going to maybe look a little different. But I think as a general rule, there's going to be a couple of phases. The first phase is going to be recovery. Is going to be getting, back to full speed, getting your staff back, getting your docs employed again. And when I say employed, I mean like actually, busy all day long and seeing a full load of patients. You're going to have to dig out from underneath the backlog that you had, because that was one of the big problems for us, is that over the course of 3 months, we would get calls from people like, hey, I need to do this. I need this procedure. Well, I need to get seen, and so when we started opening up again, we've got this huge list of people that we're trying to go through that have been just waiting for us to reopen. And so I think recovering and digging through that is going to be phase one. So getting back to busy and getting back to fully staffed, that's going to be phase one. And then that probably is going to be about all anybody can focus on during those times. So it's trying to think beyond that during phase one is going to be challenging. Once people get back to where they're steadily busy and they're fully staffed up, I think every organization needs to take stock and say, okay, how do we prevent ourselves from getting into this situation again? Okay. And so people need to take a serious look at their business practices. I think they need to start looking at, okay, are we running as leanly as we can be? One of the things that I think I've heard from a lot of folks is they're saying that, okay, well, one of the things that I've realized is that I'm not running as efficiently as I could. I've made some changes, and now we're doing things much more efficiently, and they just did it because they had to. But trying to maximize their efficiencies so they can see more patients and make maximum use of their own time. And then I think another thing is going to be important is for people to establish some cash reserves. So on a personal finance standpoint, one of the things that I always like to talk about with folks that I'm coaching is they need to have an emergency fund. So because if something like this happens where you just suddenly have no income or you have a huge expense come up, you need to be able to write a check for that without going into debt. Well, most businesses tend to run very close to the margin. And so it's going to be very important, I think, for all businesses to have cash reserves built up for at least a few months so that if something like this happens, they aren't in a position where they necessarily have to furlough all of their staff because they simply can't make ends meet. And so trying to prepare financially, and I think from a staffing standpoint for the next event, which it won't be COVID, it'll be something else, but it's going to happen. I mean, this won't be the last time we have to deal with this.
Yeah, I think that's great. And some of the advice you were talking about earlier, as far as personal finances goes, particularly for those younger physicians accumulating debt or starting out with debt, the recovery period will be interesting because, as you said, their volumes may spike up as a result of dealing with some of that and working through with some of that backlog. So maybe 3 months, 6 months, I don't know, maybe 12 months, volumes may be really high, exceeding historical levels, pre-2020 levels, but also keeping in mind that's not going to be the norm. So it is going to hopefully steady out at some point. So don't think, the income derived during those peak spike periods are going to be the new norm and the permanent solution. So again, plan for more of a steady state and develop those cash reserves. Try to create more efficiencies where you've identified some of those gaps, and I think that could lend towards much more stability after we get out of this.
Yeah, and store up for the future. Don't count on a time of plenty being, forever. So store up for the future, have some cash reserves, have that emergency fund. Absolutely.
Yeah, it's interesting too, as far as evaluating the business practices. One of the things we're about to release a series of articles on some of the things that we've identified from things that have emerged that during COVID or an event like this, some of those inefficiencies and gaps that have been identified or that have emerged. And we've gotten a lot of feedback from folks, some of our own consultants, some of our clients, some physicians out there that we know and talk to, just things that really weren't a priority pre-COVID, but once this hit, it's like, oh wow, this really exposed some weaknesses in our organization, and this is the time to fix those if there ever was.
Yeah. And that's one of the things that I like to coach people on when it's not COVID time is it's very easy for someone to get sort of in a rut where they feel like, okay, we're always trying to get back to a place of, I think, comfort and routine. Right. And it's uncomfortable to shake things up and to have someone come in and, just kind of mess with you. But I think it's really valuable, at least once a year, to have someone come in and dispassionately evaluates, some aspect of your business and say, okay, well, here's some things you can do differently. So one of the things that I like to use sometimes is like a secret shopper or like a fake patient. So you'll have someone from the community that comes in and they make an appointment and have them go through the entire process of being a patient from beginning to end. But secretly they're just, they're taking notes, they're making comments about, well, this is something that wasn't really simple for me, or this was kind of a hassle, some things I can do differently. And then, the staff has no idea. And then, we'll bring them up and go, hey, so, we had some folks that came through and audited us a little bit, and here's some things that they commented on. So here's some things we can do differently. So I think if you're constantly looking to make things 5% better, then you'll be much more flexible, much more nimble when it's time to adapt to some major change like this. So I'm a fan of the Winston Churchill quote. He said to improve is to change, to perfect is to change often.
I couldn't say it better. It's funny, we work with a number of hospitals that are very big into kind of that secret shopper type of program. It's very common, particularly with their physician network. And, that, as you referred to earlier, talking about businesses that operate on very close to the margin or very thin margins. So 5% improvement here and there can be significant. I mean, it's nothing to shy away from by any means. So I think that's excellent advice.
And it's achievable. That's the other thing, is that people feel like, you know, well, if I'm not making these giant sweeping changes, I haven't really accomplished anything. No, 5% is the difference maker. 5% is the difference between a B+ and an A, right? It's the difference between failing and succeeding. It's 5% of improvement is what makes this country better all the time. And so if everybody was trying to be 5% better all the time, I can't even imagine the amount of value we would get out of that.
Again, very sound advice that's very applicable in many ways. Dr. Lacey, I really appreciate all of the insight you've brought. Tell our audience one more time where people can find you and your content, your podcast, just so they can, and we'll make sure it's linked in the show notes and everything, but I'd love for you to kind of just let people know where they can find you.
Sure. Yeah. So I've got the website is www.thescopeofpractice.com. And there's links at the top to the blog and the podcast, and all the content's free on there. And it's got a lot of great stuff. One of the things that I always like to tell people is that if you want to be a leader, you got to be a reader. And so something that I put together for your audience, if you're interested, people can download for free. I've got a reading list of what I think are the top 35 books for leaders and people who want to do better with their personal finances. And you can get that at thescopeofpractice.com/reading list. And you read one of those books every month, and in 5 years, it's like you've got an MBA. And so if you're constantly looking to improve that 5%, learn from people that have already come before you. Take someone out to lunch that has been succeeding in a way that you want to succeed and have been doing well for the last 20 years, and just pick their brain. Read books, read biographies, just learn. That's the best thing that you can do if you want to get better.
Yeah, that absolutely. I looked through that list, and there's some absolutely excellent resources there. So I think I would encourage everybody to go check that out. And also your podcast, you have some great interviews, a lot of different perspectives, a lot of different guests that bring kind of different expertise. So that's extremely valuable content there.
Well, thanks. Yeah, it's been a lot of fun putting that together. So so people can go to thescopeofpractice.com and get access to all that stuff for free.
Absolutely. Well, again, we appreciate it. I appreciate you taking the time to talk with us today. We could have probably gone on for hours talking about some of these things and gone through a long list of questions and digging in deeper to some of this stuff. But hopefully, I really want to encourage folks to go and follow up and read some more of your content. And hopefully we'll get a chance to maybe continue the conversation in the future.
Yeah, that'd be great.
All right. Thanks, Dr. Lacey.
Thank you. Thanks a lot for having me.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We'd love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.